Okay, so today we're going to, most of the time will be about communicable disease. Actually, I didn't even check this audio. I got this new Mac that only has these C ports, and so my HDMI cable doesn't work anymore, but I believe we should be good, but I haven't tested out the audio. So it might be a moment to fix that. A little bit of overdose and poisoning, and we have a lecture to watch, which I think is the most comprehensive drowning talk that I've ever heard. I thought it was relevant since we're getting into the summer. I know that we've had quite a few already. If you guys respond, I thought I heard a recent drowning with you and another. Yeah. Okay, down to the nitty gritty because we got to start someplace, but the CDC and the WHO, they put together a list of guidelines, which then OSHA hops on board. It says that you guys need to have a standard set of precautions so that you can protect yourself from the environment and sometimes protect people from you. And then the second tier is where we'll kind of get in as well, just some other things that you guys need to think about, stuff that you guys already deal with, but like contact, airborne, that side of precautions. And in each area, we're going to kind of get into a disease that kind of affects that. But what is PPE? What do you guys need to have? What do you guys usually have on?
Gloves, eye protection, mask.
Yeah, well, those standard ones. And of all these things, and by the way, there's a tricky one, there's one not included, but with all these things, what would be the most important thing for you to do to keep yourself from getting a transmission of some disease?
Immunization. Wash hands afterwards.
Yeah, so hand washing, gloves, glasses, mask. If I were to tell you that about 60% of the things that you'll come across, diarrheal and or like virus flu stuff, would be prevented by you washing your hands for 15 seconds. That's kind of what this first set is going to kind of hammer on. When do you need it? You know, that's what we're going to get into today. Why do you need PPE? This is, I think, January of 17. There was 90,000 EMS-related injuries. The most common at 28% was just body motion, you know, too much physical effort or turning the wrong way or something and get an injury there. But shortly behind it, at 27%, is exposure to harmful substances such as fluids or chemicals or stuff that you guys will meet on the street. But how do we deal with that? First, we get these standard precautions that we chatted about. We're going to, like I said earlier, we're going to talk about contact, droplet, and then airborne precautions. So standard precautions is just assuming that everybody that you're going to come across has something that you don't want. So we're going to protect ourselves at a uniform level, and the goal is to provide a barrier from those substances to you, and those include stuff that we've already chatted about, which you guys are already pros at, so I'm not going to go into that any further, but we're going to raise it up just a notch to contact precautions. The stuff that you guys see all the time. Probably one of my favorite things to sign up for in the emergency room is an abscess. I just love watching those things getting taken care of and the smells and the oohs and ahs that go with it. C. diff, what's that? Anybody experience that? Get a call to Costa Rica when 20% of their inhabitants are affected with explosive diarrhea. These things can happen. Super difficult germ to kill and very easily pass from staff to patient to patient. Norovirus, head lice, scabs, hep A. I mean, these are stuff that's around there. And what we need to do is, I don't think you guys carry gowns, but you need to have the utmost caution of everything that you touch. You know, it can touch your equipment and then touch somebody else, or you know, you touch it, and then you'll see a video in a little bit. In about a minute time, you inadvertently touch your face or your eyes about 3 times. So just be aware that like some stuff that we do normally, it will expose us to these things. You guys have gowns?
Yeah, they just fold it up and they're in those side pouches.
I mean, if you go into like an explosive diarrhea case and it looks like you're gonna have to manhandle somebody, that would be a perfect time. Out of all these things on the left, which one can be So you guys use like Cavicide or to clean your stuff. The only one that won't work with Cavicide is that C. difficile as a bleach-based component. And it's really easy. You can just dilute like a 10% bleach solution and have like I think it's a 45-second exposure would stop the C. diff or stop the C. diff in its tracks. So the goal is, like we talked about, you can add that gown, but we're always going to have the regular PPE on us. But be diligent about stuff that can splash. Man, I remember the very first call ride-along that I went with AMR when I was going through EMT school. We got a call to this lady. She said her stomach hurt. We ended up AMAing her. I think it was a problem with her diabetes. And then an hour later, or maybe more, we came back. She was sitting in the middle of her queen bed, and not only had it pooled around her, but the diarrhea had waterfalled over the bed. So it was just a tremendous amount of material. So getting her off of there without getting it on ourselves, I don't remember what we did, but that's your contact precautions for you.
It's essential to wash your hands because 50% of all foodborne illness has been tied back to unclean hands or unwashed hands or improperly washed hands. A critical finding has to do with the duration of washing your hands. The CDC recommends 15 to 20 seconds of actual engaged hand washing to make sure your hands get clean. And we found the overall sample we had, over 3,700 observations, only 5% wash their hands more than 15 seconds. So 95% of the people we observed didn't follow the CDC's recommendations. A lot of dirty hands out there. Only 50.3% of men wash their hands with soap. And of those who do not, 15% don't wash their hands at all. 78% of women wash their hands with soap. And only 7%, half of what men do, leave their restrooms without washing their hands. We know also the CDC has suggested that the best way to prevent any type of illness is to keep washing your hands and have clean hands. So it's essential for well-being and for environmental health.
And you would think this stuff is so obvious and basic. There's a huge campaign where I work right now with the same thing. But man, it's hard to, we really don't have enough time a lot of times to wash our hands properly. And by the way, if you're wondering what that is like when you don't have a clock around you, it's basically scrubbing your hands to happy birthday twice is the amount of time that they want you to sit there and scrub your hands away. And it's just all data driven. It's like you need to actually get in there and scrub to like release the bond. That much time.
What about the addition of using like Perel or one of those?
Yeah, I've never heard, I don't know the data on hand washing and then using that. I know data that supports both rubbing with an alcohol base until it's dried and hand washing by itself. They're both pretty much equivalent unless you know that you have actual like soil or some component on your hands. But using alcohol base is just as good. Of course, like we talked about, it wouldn't work on something like C. diff, but overall it does a fantastic job. But I don't know any data on both of them. It might be redundant, but I can see why it would hurt. Okay. Who knows anything about MRSA? That's the last component of this contact base. Another thing that you guys will meet.
Besides being bad.
You're going to see some data in here that talks about how 30%, I believe, is of hospitalized patients have MRSA, whether that's not their issue or not. And when we hospitalize somebody, we will swab the inside of their nose just to kind of gather data. Most of the time it's for flu viruses. But I guarantee you that a majority of us just have MRSA on us, just on our skin. And it doesn't pose a problem until we cut ourselves or something, and then we also have another disease process where our immune system is totally broken down. So MRSA is here. I mean, we have E. coli in our GI tract. It doesn't bother us, but it's there until we disrupt something.
I had surgery not too long ago. They swabbed my nose. I had MRSA in my
Right.
passages.
Yeah, it wasn't a big deal. It's just there. And in our industry, because we're around it so much, guys, I guarantee you, he's not
You've all
alone.
probably heard of the superbug MRSA, but what actually is it? Find out in this Sick Notes. Hello, I'm Dr. Ed Hope and welcome to Sick Notes, where we make complicated medical language easy to understand. Today we're talking about MRSA. MRSA is a bacteria, and if this causes an infection in the body, can be difficult to treat with antibiotics. There are millions of bacteria everywhere in our environment, on our skin, and even in our bodies. In fact, it's a lot like the Force in Star Wars, surrounding us, penetrating us, and binding the galaxy together. Bacteria are tiny living things made up of just one cell. Most bacteria are harmless, some are even useful to us, but unfortunately some can damage our bodies if they get into the wrong place. If this happens, we call this an infection. Infections can be caused by other things like viruses, fungus and parasites. Common sites of infection are the respiratory tract, so the throat and lungs, the urinary tract, what we call a water infection, and the tissues under the skin, what we call cellulitis. During an infection, the bacteria damage the cells of the body, leading to inflammation. That's why it becomes painful, red, hot, and swollen at the site. If your body's immune system is unable to deal with the infection, then antibiotics can help stop the bacteria growing. Unfortunately, if the bacteria continue to spread, then this can lead to an overwhelming infection, which we call sepsis, which can be fatal. MRSA stands for methicillin-resistant Staphylococcus aureus, which I see you all falling asleep at, but just let me explain what that means. The Staphylococcus aureus part is just the type of bacteria. This bacteria tends to live in the throat and skin and doesn't cause us any problems unless it gets under the skin. If it does and causes an infection, we can treat it with antibiotics. However, MRSA is a strain of Staphylococcus aureus that lives on about 1 in 30 people. Now this is slightly different. The methicillin-resistant part of it means that it's resistant to certain antibiotics. So if this strain causes an infection, it's more difficult to treat. Hence it obtaining the nickname a superbug. Superbugs are a wider public health issue and all down to the overprescribing of antibiotics for things like simple colds. This means the bacteria get exposed to the antibiotics and therefore can evolve to deal with them. This is called antibiotic resistance. As MRSA lives on the skin in about 1 in 30 people and never cause a problem, we call it an opportunistic infection. Therefore, it is most likely to affect vulnerable people, particularly people in hospital. For example, in hospitals, we're doing surgical procedures where we're making incisions into the skin. We're also taking blood and putting in cannulas, which also can introduce infection under the skin. And we also sometimes need to put in a catheter, which can also introduce infection into the urinary tract. And don't forget, in hospital, people are also generally unwell with multiple other illnesses. This can impact on you, particularly on the immune system, and make it more likely that an infection can occur. Therefore, if anyone comes into the hospital as an inpatient, they'll have a swab for MRSA to see if they're one of the 1 in 30 people that carry it on their skin. If they do, they'll have an antibacterial wash, which will reduce the numbers of the bacteria and reduce the chances of getting an infection. So I hope this has helped your understanding of what MRSA is. I've put some clarifications and some useful links in the description below. If you like this video, you can subscribe or share it. Thank you very much for watching.
Why did I bring this stuff up? Just because, and we're starting here with contact, and it's going to fold into the rest of the stuff we see. But you guys are out there in the public. You're seeing babies. You're going to Costa Dinner. You're seeing people with a whole bunch of comorbidities. You know, a bunch of diseases that is going to make them more susceptible to these types of issues. So back to hand washing. So it's estimated that, and this is all CDC stats. Washing your hands with soap and water will reduce diarrheal disease-associated deaths by 50%. A worldwide search in London says that everyone routinely washes their hands, 1 million deaths a year could be prevented. A large percentage of foodborne diseases outbreaks are spread by contaminated hands. Appropriate hand washing procedures or practices can reduce the risk of foodborne illness and other infections. And hand washing alone can reduce the risk of respiratory infections by 16%. This these aren't just third world stats. So do we have an issue with diarrheal infections? I mentioned C. diff. When there is a case around where our ER gets infiltrated with like 30 or 40 people, most of them are old and some of them do die. You guys will see that here in your career where there will be an infection at Costa, just very cyclical. It'll happen. Respiratory infections, hand washing, I mean, every year we have the flu. That's how this thing spread. So simple hand washing is very effective. And when we look at global stats, this is from 2016, 2 of the top 5 leaders can be prevented, or at least a lot of it, from regular hand washing, respiratory infections, and diarrheal disease. Before moving on, have you guys, they're talking about antibiotic resistance, and as we're moving forward, we're losing effective antibiotics. I'm sure you guys have heard of them. Have you guys heard of the technology called CRISPR? And for those who haven't, it's a very, at least at this point, it seems very Frankensteinish, where we will basically have a virus that can go snip out a piece of DNA and either take that out or insert something else. And it's very, I mean, we're talking turning Chihuahuas into Great Danes, making strawberries taste like watermelon. That's the stuff that theoretically we could do. But the reason I bring it up is because supposedly it'll be the next antibiotic too. We can determine what type of bacteria that we're dealing with and then send a virus in there that will only take out that bacteria.
There's a doctor in China that genetically spliced a
Kids.
kid and made him resistant to, I can't remember what the disease was.
And I think it was controversial, like embryonic CRISPR stuff. So there's a whole bunch of ethical issues with that, but you'll be hearing more and more about that as we lose more and more antibiotics. Any other questions about contact precautions? Again, it's gown would be the upgrade for you guys other than your standard PPE. Okay, we're getting a little nastier now. So droplet precautions, basically we want to stop the spread of tiny little droplets that are in the air that you can inhale yourself. There's a bunch of different meningitises. That meningitis is not the one where you get petechiae in your limbs and you got to get your limbs cut off and very few survive. Mumps, strep and other type of pneumonia causes. What about pertussis? What's that? Whooping cough. Most people are vaccinated against that. How about rhinovirus? Any idea what that is?
Common flu, right?
It's a common cold. Yeah, it's a virus that causes a common cold. There's about 200 something varieties of rhinovirus, and then the seasonal influenza. So if you're going to be within a 5-foot radius of someone coughing and sneezing and spreading, 30,000 super tiny droplets with 10,000 viruses in each one, then you need to get one of these simple surgical masks on. Usually the thing that separates a lot of these people, at least for flu, and you'll see a video about it too, is just like if they've talked about having cold, feeling cold or recording a temperature. Then you know that you've really hit this area where droplet precautions are very pertinent. How do you guys roll? Where are your masks at? When you walk into a situation, you realize you're over your head. You gotta go back and get them.
Yeah, I really got seems like we rarely use those.
There's a couple of bad.
Does that ever happen? Do you guys ever wear them?
Last time I used one, we put it on the patient.
Okay, that's fair enough. Someone still had to go get it.
We had it with us.
Okay. Speaking of masks, I think we're out, well, at least in my work, we're out of the flu season, but are you guys mandated to get flu vaccines? Is there an option out?
Yeah, it's just
And it's a mask? Okay. We're gonna delve a little bit into the ethical portion of that and vaccines as we go along. But hey, if you're with greater than 5 feet, you're even with something like meningitis, your chances of getting it shrink down to like into the 1% area. So distance obviously helps. Any type of draft in your favor helps.
It often begins with a tingle in your throat or a single sneeze, followed by a headache, drowsiness, a runny nose, and nagging cough. It's official. No matter how quickly you chug that glass of orange juice or lather on excessive amounts of hand sanitizer, you've caught a virus. Now the question is it the constantly mutating influenza virus known as the flu, or is it one of the 200 strains of the common cold? Because yes, there is a difference.
Influenza tends to be an illness that has a sudden onset, more likely to cause a high fever with aches and pains and runny nose.
In other words, when you've been hit by the flu, you'll know. The influenza virus is responsible for some of the deadliest pandemics in history, including the Spanish flu in 1918, which spread across the US, Europe, and Asia and affected a third of the global population, killing up to 50 million people worldwide, 8 million in Spain alone. In fact, more soldiers in World War I died from the flu than the actual battle. But the pandemic flu is a completely different beast. Let's just focus on the seasonal flu and the common cold. While both attack your respiratory tract, the cold tends to stay up in the nose and sinus area, whereas the flu can enter deep into the lungs and cause complications, especially for young children, people over 65, pregnant women, and individuals with long-term medical conditions and weaker immune systems. Cold symptoms are much milder and more common, hence common cold. And the most common of common colds, the rhinovirus. On average, adults get 2 to 3 colds a year. It's one of the leading causes of missed days of work and costs close to $25 billion annually in lost productivity in the US. Unlike the flu, which has a specific season between October and May in the Northern Hemisphere, the cold can hit at any time of the year, but is also more common in the winter months. But contrary to popular belief, you can't actually catch a cold in the cold. You're more likely to catch one here, inside a closed space where viruses are constantly circulating. The reason we get sick more in the winter is simply because we herd together indoors, the windows are shut, and we're more likely to breathe the same air as someone who already has a virus. Whether it be a cold or a flu, the way the virus enters your body is the same. Take this scenario for example. John Doe is sitting on the bus while battling a viral infection, and here comes the sneeze. Before he has time to cover his mouth, projectile containing nearly 40,000 tiny virus-filled droplets are expelled into the air. Those particles can fly up to 2 meters, making anyone nearby a target, including unsuspecting Jane. The pathogen enters the lining of Jane's respiratory tract and uses its protein spikes like a key to enter a cell, hijacks the nucleus, and begins replicating even more viruses. Symptoms usually start within 1 to 3 days after being exposed to the virus. Those first 3 days of coughing and fatigue are when you are the most contagious to others. By now, Jane already spread her germs to her partner at home, and they've both taken their viruses to work, contaminating different surfaces, which then spread to their coworkers. And that's one of the fastest ways we spread germs.
It can survive on surfaces for at least up to a day and on skin for an hour. So you might shake hands with someone or touch a doorknob, and then afterwards if you touch your eyes or your mouth, then that's one way of infecting yourself.
On average, humans touch their face 3 to 5 times every minute without even realizing it. Most of the time, your body is strong enough to fight off infection pretty quickly.
We have antibodies that are created that will neutralize the virus in the nasal passages. And when that happens, eventually after a few days, the virus becomes inactivated, neutralized, and then the body can heal.
Generally, colds clear up within a week to 10 days, but the post-viral nagging cough can linger for weeks till it eventually resolves on its own. In the meantime, another cold virus could be lurking just around the corner. Influenza could last up to 3 weeks. The virus spreads rapidly, causing your body to respond more aggressively. One of the biggest differences between the cold and the flu is that the flu usually comes with a fever, and symptoms like that have less to do with the actual virus and more to do with the immune response. Over-the-counter medications like acetaminophen and ibuprofen can help control those symptoms. Antibiotics, on the other hand, treat bacteria, infections like bacterial pneumonia and strep throat. It will not help you when you have the flu or cold and will in fact do more harm than good. So what can you do to protect yourself from getting sick? Your immune system's great memory will in part help you with that. Every time a virus is destroyed, B and T cells remember that particular strain so it can react faster the next time. And that's similar to how the flu vaccine works. An inactive virus is injected into your system, just enough to trigger cells into action. Health officials say it's the no-brainer defense against the flu.
So if everyone in the general public gets it, then the old and the young are protected. So you're not only protecting yourself, but you're protecting everyone else.
And although not 100% perfect, it still reduces the severity of your symptoms if you do end up getting sick.
Done.
So easy.
So what about all those remedies that are often touted as a way to fight a cold or flu? Well, here are the facts. There is no evidence that vitamin C fights a virus. In fact, too much vitamin C supplements can cause stomach pains and diarrhea. Zinc has shown to reduce the length of a cold by a day, but doctors caution the high dose comes with side effects, including nausea, so it may not be worth it.
As for chicken soup, the benefits are still up for debate. But if it's comforting, then why not? In the end, the only actual cure is time.
We've just got to accept what is happening inside our body and ride it out. The best thing you can do to prevent getting sick is wash your hands as often as you can for at least 20 seconds, especially after contact with individuals or contaminated surfaces. Stay home from work when you're contagious. And finally, practice good cough and sneeze etiquette, because yes, there is a right way to do it.
If you enjoyed what you saw, like the video.
Okay, again, this is super basic stuff, but I'm telling you that people die from this stuff. You can protect yourself and protect others by just learning a few simple tips. And man, unfortunately, even we get a couple cases a year where we get somebody that's healthy and strong and we lose them to the flu. Those are very small percentage, but man, it's crazy. The flu comes and goes all the time, and it affects even first world countries. How do we know? First of all, if you get a flu vaccine, are you guaranteed not to get the flu? Why is that? Okay, there's different strains. And by the way, we'll get into some territories that might be sensitive. You don't have to respond, but the banter is appreciated. Okay, so there's hundreds of different flu viruses. How do they know what to give to us? Okay, good. I heard a couple things. I heard last year's stats. I heard, what did you say, South?
Last year, South Africa determined what they gave us.
Yeah, that's getting super close. But basically, we look to see what the southern hemisphere is doing, what's affecting the southern hemisphere during our summer season. It's affecting them, and we base statistically what affected them is going to come affect us in the flu season. So we look down there and vice versa as to what strain of flu is going to be the most effective. How good are they at predicting that? Even though, again, this is very cyclical, how well this happens. And unfortunately, if someone gets the flu shot and they still get the flu, then they feel like that's nothing that they ever want to be a part of again. But they're over 50% effective. I think I saw stats about 65% of the time they get the flu virus that will affect most of us. Is it safe?
For sure. Yes.
What happens? What is the flu shot? What does it do to us?
It's like the flu cells,
Yeah.
promoting antibody production.
Yeah, okay, so they basically inject us with a dead piece of material that our body can figure out the lock and key mechanism and develop antibodies for when we see that again. So basically it is send something in there, a dead piece of material, that now our bodies can figure out, like, I don't like this, let's prevent it. If it ever comes again, let's build up an army. That's like the really 5-second scenario. What else was I going to say?
About the duration, if it wasn't the exact strand, I've heard people say that too.
Yeah, so then if you get the flu, or you're asking, does it decrease your amount of time being sick? And from the data I've read, yes. I can't say yes or no to you, but I've heard that it decreases your time.
So it makes sense. So you would think that the lock and key mechanism would be at least close to the other ones. So.
I think it was about it. Can pregnant women get them? The answer is yes. I believe it's, I'm getting into gray territory. I think under 1 year of age, they don't recommend the flu shot.
Now you said dead cells. People still get sick from the flu shot. Is that not true? Or?
Yeah. So thank you. Well, the number one thing that happens is people will get like irritation from the area, and sometimes they'll get a fever just because the body is like, hey, there's something foreign in here. It's it's starting its own war. Everybody has a different sensitivity to that injection. However, most of the time, and we're going to get into this because we're going to talk about vaccines and autism in a little bit. Most of the time that people are getting the flu shots is during flu season, so inadvertently they could also have co-exposure at the same time. So when that happens again, that's another person that's just like, dude, I got the freaking flu vaccine, I got poked, and I also got the flu. Like, that'll be the last person to ever get vaccinated again because they had a horrible experience. But can it come in the, can you get a flu shot and then have symptoms? Yeah, but they're not full-blown like diarrheal vomiting type of thing that you get from there. But you could get exposure to another flu that you haven't been vaccinated to around the same time because people get the flu shot at that time.
I can see that, especially when it's like everybody they know has the flu. Everybody gets the flu shot, they've already exposed.
Yeah. And by the time that they notice that their friends are having all these symptoms, they're like already days into their own incubation period.
So there's injection for vaccination, and then there's also
There's a nasal one.
Mm-hmm. And that's different mechanisms, right? For
what they're putting into you. Yeah. I know that there is. I didn't research that before coming here today, so I'm not sure of the how many of those people are now immunized that year from it. I think that the data is probably pretty good in order for it to be released, but I'm not sure. And it's very popular for children. Okay, we're cranking it up another notch here. Airborne precautions is when basically you're dealing with these super small particulates, and these are really nasty diseases. We'll get into measles. Monkeypox is like a super gnarly chicken pox where the bumps are almost golf ball size, almost like a leopard kind of look. Those are usually in near jungle areas in Africa, and a lot of times people that are eating like game meat get monkeypox. We'll talk a little bit about TB. What about varicella? You guys know what that is? That's our chicken pox. So we need to provide respiratory protection against these infectious agents that can travel over long distances, and like the last one, they can stay on surfaces for an enormous amount of time. What does the 95 mean in the N95?
95% infiltration.
Yeah. And then it also, very good, thank you for paying attention. It also affects us because of basically the hole in the size of the mass. So TB is about 2 to 4 microns in length, and then the diameter of the holes in the N95 is only 0.3 microns, so super, super tiny. I know from talking to City earlier this week, they get fit tested for their SCBAs, and I'm sure you do too. But do you guys get fit test? Does that include your N95?
It's supposed to.
Yeah.
We're running that program.
Our new machine we're getting a new machine that's going to be able to do that.
Yeah. And the only reason I bring it up, because I always hated just wasting my time going to a fit test. But if we're talking about something super important where you can get a disease that'll last you for the rest of your life, N95s are basically a one-size-fit-all, but there are people that it just doesn't fit. So in that case, I would want to try one in on a fit test so that you can, what is it? It's pretty bitter. Is that what the smell is? Like you feel it in your mouth? If you're the face that doesn't fit your like standard issue N95, then you need either one, ask your department to help you buy a box that would fit you, or for less red tape, just go out and get one that will work, because these things are important. If you get TB, does that mean you have to quit the fire department? What does it mean?
Doesn't mean you're contagious, it just means that you carry the antibody,
Okay.
right?
Yeah, that's totally right. And almost, if I don't want to link it to like the AIDS epidemic, but nowadays you can basically suppress TB for the rest of your life through meds. And unfortunately, I think it's an annual X-ray to see if things have grown. And so you'll always test positive on the skin test. But does that mean that you have to hang up your cleats? No. But you'll have to go through a regimen that basically keeps it at bay for the rest of your life. I think that's all I have to say about TB, at least right now. Is this in your rig too? Okay. How do you know when to put one on? You go into a room where someone has this nasty ass cough, you hear talks about fever, we're going to only go into a couple of these things, but you see petechiae. I mean, these are like red flags, should be waving high in the wind, like stand back for a second. Let's like come back in more, ready for the situation.
Tuberculosis, or TB, is as old as man himself. In ancient times, it was known as phthisis, which means wasting away. It was first described by Hippocrates. A pulmonary infection manifesting itself as weight loss, a cough, and blood in the sputum, which gradually led to death. In the 16th century, Italian doctor Girolamo Fracastoro proposed the theory that the disease was transmitted by a microorganism, invisible to the naked eye. In 1818, French physician René Laennec invented the stethoscope. Auscultation with the stethoscope revolutionized diagnosis of tuberculosis, but it was still not known how it was spread or how to treat it. Cures in sanatoriums were fashionable. Fresh air, rest, and a balanced diet were used both to isolate patients and treat them. In 1882, German physician Robert Koch discovered the tuberculosis bacillus that bears his name. From then on, it was known that Koch's bacillus is spread through the air. Nicknamed the White Plague in the 19th century, tuberculosis was a great romantic, carrying off Chekhov, Chopin, Kafka, and Schiller. During that century, it was improvements in living conditions and hygiene, not medical advances, that curbed the spread of the disease. It wasn't until the 20th century that the BCG vaccine was developed, and even more importantly, the first antibiotics capable of effectively treating the disease were discovered. Wealthy countries were finally able to forget the disease, until the 1980s, when it resurfaced along with the AIDS epidemic. People living with HIV have weakened immune systems, and so are more susceptible to tuberculosis. Meanwhile, resistance to antibiotics is becoming increasingly common. Every year, tuberculosis kills 1.3 million people. 9 million fall ill, of which 500,000 with a multi-drug resistant form, meaning antibiotics are ineffective. And these numbers are probably underestimated.
What other name does TB have historically? Consumption. Why do you think that? Yeah, they basically just withered away into nothing. We probably, in the emergency room, I probably get about maybe once every 3 months we get a TB patient. But most of them are brought in from the county. County tracks all the TB cases, and Either there was a change in the patient's condition or they're not responding to antibiotics. And so the county brings them in and they don't even go through triage. We have these negative pressure rooms that we put them in. Anybody are positive for TB that has to go through that treatment here in the room? Okay, let's keep it that way.
So having a positive reaction, skin reaction, doesn't necessarily mean you have TB? Or
No, it means that yes, you have TB, but it doesn't mean that you're infectious. Yeah, so you can test positive, and you probably will test positive forever, because once you have it, you have it. But it doesn't necessarily mean that you're communicable, that you can pass the disease on.
This is a chart of reported measles cases in the US. In the 1950s, measles was one of those diseases that nearly every child got. It caused a high fever and a spotty rash all over the body, and while most recovered easily, it still killed around 500 children each year. Then, in 1963, a vaccine became available, and measles became an easily preventable and unnecessary disease. By 2000, measles was officially eliminated in the US. And for a time, less than 100 Americans a year got it. But in the last decade, that number has started to grow. Now, there have been more cases through the first 3 months of 2019 than in all of 2018. Measles is back, and to understand why, you have to understand where it's back.
Measles can be quite serious, but now no one needs to get them.
Here are those recent measles cases again. If we look at the 2013 spike, we notice something. A good chunk of those cases can be attributed to an outbreak among Orthodox Jews in New York. That huge spike in 2014, most of those cases are all from one outbreak among the Amish in Ohio. 2017, one outbreak in the Somali American community in Minnesota. 2018, different communities of New York Orthodox Jews. And again in 2019. What all of this shows is that the return of measles isn't as widespread as you might think. 75% of recent cases have happened in these close-knit communities.
People in these communities tend to read the same news, watch the same TV programs, speak the same language.
Julia Belluz, Vox Health reporter.
They go to school together, they worship together. When not enough of them are vaccinated, it tends to spread like wildfire.
Like in early 2019 outside Vancouver, Washington, where a measles outbreak sickened 73 people. It originated at a local Slavic church, likely from someone who picked up the disease in Eastern Europe. It quickly spread through the community, infecting mostly small children who weren't immunized. One reason this happened is that the Slavic community in Washington has one of the lowest rates of vaccination in the state.
Some of the people in this community don't trust doctors.
Yuri is a member of that community. He's also a health data analyst.
They have a view that big pharma is too ingrained with the medical establishment. They are much more willing to listen to members of the community.
Anti-vaccination misinformation can reach anyone, but it's in these small communities where it does the most damage. Most people in these communities are vaccinated. The problem starts when not enough people are vaccinated. It prevents them from reaching what's called herd immunity. Here's how it works.
With every vaccine, you need a certain percentage of a community to be immunized in order for the vaccine to work.
If a group of people comes into contact with one person contagious with measles and none of them are vaccinated, virtually everyone will get sick. If 50% of the group is vaccinated, that's not enough. The rest are likely to get sick and spread the disease. But at a certain point, if enough people are vaccinated, they can actually protect the few that aren't vaccinated from getting sick, stopping the spread of the disease, herd immunity. This is important because there are people who can't get vaccinated because of their immune system, people like cancer patients and newborn babies.
And with measles, because it's so contagious, that number is just really, really high. It's 95%. So basically everyone who can get vaccinated needs to be vaccinated. We're protecting all those people who can't get vaccines.
That 95% number doesn't leave much wiggle room, and a lot of US states are now struggling to meet it. These are the states where the number of kindergartners vaccinated for measles is below the herd immunity threshold. It's half of states. So how do we make sure everyone who can get vaccinated does? It might help to look at it this way. These are the states that allow parents to opt out for religious reasons, and these are the states that allow parents to opt out for any philosophical reason. And then there are a few states that allow neither.
The two states that have had no exemptions for a very long time, Mississippi and West Virginia, they haven't seen these big outbreaks in recent years.
Part of why Washington's Slavic community has such low vaccination rates is simply because Washington allows them to easily opt out. In parts of the state, including where the outbreak occurred, the amount of vaccinated kindergartners has fallen way below the amount needed for herd immunity. But since the outbreak, legislators in Washington have introduced a bill to get rid of non-medical vaccine exemptions. Maybe the best way to make sure all communities reach herd immunity and protect those that can't be vaccinated is to just not let them opt out in the first place.
Why is that such a big deal? What kind of twofold question for you guys? Let's just talk about measles. Does anybody know what some of the downsides of measles are? When I grew up, chickenpox, if someone got it on our street, everybody sent their kids over there. I have some stats here in a minute, but I believe that 1 in every 1,000 children can go deaf. I think 1 in every 3,000 to 5,000 a child dies. And it can cause other nasty stuff like meningitis, and I mean, it's pretty wicked. However, there are a lot of people that survive through that and will never have to deal with that again. The other thing is, I'll show you guys some school data, is that you guys are not, this area is not a herd immunity area. And we'll look at some data about, is not, well below the mark. And we'll look at some data here. All right, I do have some 2019 data as of a couple days ago. By the way, there's 981 cases this year in the US, and since this was published a couple days ago, there's 41 new cases. So this is all CDC stats again. They say that over the past 2 decades, vaccines have saved almost 800,000 US children from dying, or from getting sick. Over 90% of vaccine side effects are not serious. We talked about those, are just like inflammation, redness at the site, and a low-grade fever. More than 20 rigorous scientific studies have shown there's no link between MMR vaccine and autism. And the only study, there's only one, that was created to show that link has been discredited and retracted by its author. 1 in 10 children get an ear infection. We talked about the permanent hearing loss. For every 1,000, 1 or 2 will die from the disease. The last class that I had, which is kind of our next topic, where I kind of let the class just kind of evolve, and we talked about vaccine and is this good for your children or not, and is it a parent decision, and a couple of them were just against vaccines, not because of any type of data, but just because of like their liberty, which is a big deal. I can't argue against that. What do you guys think about all that?
I think that they should not be allowed to go to school if they're not vaccinated.
Okay. Anybody else?
Seems like you could put in place a lot of measures to encourage the population to get vaccinated. But somewhere you draw the line, right? Holding people down and shoving needles in their arms, right? So.
95% is a lot. I mean, to get 95%, and measles is an outlier because it is so infectious. It needs that percentage. Some of the other diseases don't need that. But getting 95%, and this includes people that can't get it, these babies and people with cancer and other types of diseases. But getting that number is a huge chore.
The vaccine's tied to mumps and rubella as well. So
You get a threefold in one shot is what you're saying. Yeah. It's the MMR, right?
Are those, they're not nearly as high as a
infectious issue? Yes.
The herd percentage is not as high?
You don't need to be as high with those two, but everybody gets like the MMR vaccine, right? Because it includes the measles in there.
Are there areas that are over 95%?
Sure. Oh, yeah. But not around here. we'll look at it in a minute. We'll watch this video first.
Baseless claims about a link between vaccines and developmental disorders have fueled the so-called anti-vaxxer movement for years now. But in Texas, the anti-vaxxers are motivated by something else, an unconditional commitment to personal freedom, even at the expense of public health.
A parent decides whether their children get vaccinated or not. That is it in a nutshell.
In 2003, about 2,000 kids in Texas held exemptions, allowing them to opt out of vaccinations for non-medical reasons. Today, that number has risen to almost 45,000. More than 20 vaccine-related bills were introduced in the recently completed 85th Texas legislative session. And while some of those bills promote vaccinations, others definitely don't. 31-year-old Republican State Representative Briscoe Cain is a member of the state's Freedom Caucus. Why is the debate about vaccines so strong in Texas? Is this something specific to Texas?
It's kind of something in our history, in our DNA, that we desire to be free from government intervention in our lives.
From your perspective, what's the vaccine choice debate about?
The parent should have the ability to decide whether or not their child takes medicine or receives an injection. It's about liberty.
So it's not about vaccines themselves or their safety?
For some it is. For me personally, it has nothing to do with the science or debating the science of vaccines.
Do you get vaccines yourself?
I do.
Do you have children?
I do. And they've been vaccinated.
Okay.
Yeah, I mean, I grew up getting the flu shot every year.
Mm-hmm.
It's purely, but it was at my own choosing.
Some vaccines are only like 97% protective. So hypothetically, if your child were to get the measles from a child who wasn't vaccinated, how would you feel about that?
It's troubling that my child got the measles.
I mean, there's an outbreak right now in Minnesota.
I believe that personal liberty, or my personal liberty, stops at the person of another.
What about when a person's personal liberty infringes on somebody else's safety?
I believe that in the hierarchy of rights, that liberty is higher than safety and security.
When Briscoe talks about fighting for parental rights, it's people like Stacey Methin that he has in mind.
This is an exemption form. This is for me and my son.
She's previously filed exemptions for her 11-year-old son, Christian, the youngest of her 5 children. Christian hasn't received any vaccines since he was 6. Could you walk me through some of the documents that are in here?
This one is one of the first ones that I actually went and researched. And it talks about the role of the federal government. But it doesn't give them the right to mandate vaccines. We have a right on this planet to choose for our own bodies what we take in. And it should be the same way with a shot or treatment.
In Texas, non-medical or conscientious exemptions from vaccines can be granted for any personal reason, including religion. Stacey is studying to be a nurse. She claims that 2 of her grandchildren were injured after getting vaccinated.
My attitude with life as well as vaccines is that if you believe in it, you push for it. It's hard for me. Yeah. It's hard for me to think of a future where other children would lose their rights and continue to be injured when none of us knows why.
Do you think that's a possibility? Do you worry about your rights being taken away?
I worry about the rights of my children and all of the other children out there.
Help get the eggs?
Okay.
Heather and David Pencil are worried too, but for a different reason. They live in the Austin suburbs, where public school districts have some of the highest exemption rates in the state. And private school exemption rates run as high as 40%. The fact that you live in Austin instead of New York City, for instance, puts your family more at risk. Yeah. What happens if there's a measles outbreak here?
Bar the doors!
Right, yeah, So, say baby is younger than 6 months. I would genuinely be concerned because measles is a serious disease. I mean, it can cause encephalitis, it can cause deafness, lots of things.
A bill introduced this year would have made exemption rates for individual schools publicly available.
But in May, that bill stalled out in the state legislature after the Freedom Caucus opposed it for infringing on personal privacy.
How does it make you feel that the debate right now is people putting their privacy above other people's health safety?
It's a privilege issue. They are more concerned about their children than the risk of the greater population. And it's a false risk. Because that information is already available at that level.
It's already being collected.
Yeah, I mean,
you just wish that you could just...
Yeah, it should be available to parents. You know, it's a public health issue.
Peter Hotez, a vaccine expert and dean of the National School of Tropical Medicine at the Baylor College in Houston, has been contending with dangers of the vaccine choice movement in Texas for years.
A group of anti-vaccine activists have somehow convinced a large number of people in the state of Texas that this is a civil libertarian issue. And I don't accept that. What about the civil liberties of a young mother, a young parent in the Austin, Texas area? If I'm a mother of a young baby under the age of 12, because we don't vaccinate kids till 12 to 15 months with measles, I'd be terrified. If you're a parent, you're required by law to strap your child in a seatbelt in the car, right? That's not a parental choice. If you own a gun, and a lot of people in Texas own guns, you're required to lock that gun if you have a child at home. Right. And it's the same for vaccines.
Is there anything in Texas right now that could stop that from happening, stop outbreaks from happening?
We could proactively block outbreaks from happening tomorrow. And it's very simple. All we have to do is what was done in California when they had measles outbreaks. The state legislature finally woke up and they said, oh my God, what have we done? And they closed all the non-medical exemptions. And guess what? Vaccine coverage rate went up and problem solved.
Do you see that happening in Texas?
I don't, and I've been saying this now, and it's very sad that the only thing that's going to stop this runaway train right now is a large measles outbreak.
Super hot button issue. I can't tell you when I was trying to find some things to show, whether I was on some type of social media or YouTube, I had to really scrutinize my search terms because the anti-vax stuff is there and it's overwhelming. And if you think that you want to research it, there's just so much stuff. And
squeaky wheel gets the grease, right? I mean, the loudest voice is the one that's typically heard. And
yeah.
So it's a lot. We have that a lot in this country where a small minority of individuals speaks the loudest, and that all of a sudden becomes the overwhelming theory, which whether it's right or not.
Maybe that's not a very good term for me to use because I have friends that haven't vaccinated their children. They're still my friends. It's just an idea. But since we were talking about it, here's the 2016-2017 data, and these are schools here. There's only 3 of them that are not in the South County. There's Lompoc and Solvang. But here's the percentages of people that are up to date. And this is page 1. This list that I was on includes the whole county of Santa Barbara, but this is page 1, so these are like the heavy hitters. One school on this page meets the herd immunity standards, but so we have Waldorf, we have Crane, Cold Springs, Montessori, Montecito Union, Santa Barbara Charter. All these are, below this 95 percentile. And he was give California as an example of us having legislation that doesn't allow it. Here are the categories that they fall under, either a medical reason or a belief reason is why they opted out, or they're just choosing not to show up at their doctor's appointments to get it done.
I thought California had taken out the exemption for anything other than that.
They have, but here's the 2016-2017 data. I don't know the ins and outs of how they're able to keep going, but there's the data. 25% at Waldorf. There's a family on my street that goes there. I haven't asked them about vaccines. Seen a little bit, boys?
So by way of introduction, I'm Justin Semstrat. I'm an accident and emergency physician in the U.S. and have been an ocean lifeguard since 1996. I'm the founder, executive director of Lifeguards Without Borders. So I have no financial conflicts to disclose. Some of the feedback that I've received from similar presentations, there's graphic videos and still images of both fatal and non-fatal drowning patients, and that is something that some people find disturbing. And we're going to be talking about the pre-hospital treatment of drowning. This should not supplant your local medical direction and your local protocols that you should follow. And if what is presented is different than what you're doing, then hopefully it should stimulate discussion with your leadership more so than you changing your practice style based on one presentation. So if you can't really tell what's going on here, this is actually the first known documentation of a drowning resuscitation. There was a big battle in Aleppo, Syria on the Orontes River, and it was documented here in 1237 BC with the great, presumably the prince or the king of Aleppo, being held upside down by two of his lieutenants to drain the water from his lungs. It was unsuccessful, and unfortunately it's an idea that has persisted through today in drowning resuscitation. In the Far East, which was intellectually separate from us in the West, there was still this idea that we needed to warm these patients and that smoke had some sort of properties and that we needed to drain the water from the lungs. And the one on the bottom right there over the ox was done in the American West as well. If somebody went unconscious at a saloon, you would throw them over a horse and gallop them in a circle in a chest compression-y, Heimlich-y, something that was better than the nothing available at the time. Our friends on the other end of the world in New Zealand did some pretty interesting, groundbreaking work where they actually administered carbon dioxide to their patients, thinking that if the CO2 levels rose, that it would stimulate them to breathe. Obviously, another unsuccessful technique. By far everyone's favorite, this idea that tobacco had stimulating properties, particularly if instilled in the rectum, which is where we come up with the phrase of to blow smoke up someone's rear end as an ineffective measure of something that we do. You can imagine that this was a technically difficult task, and so these are actually tobacco bellows and tobacco enemas so that you can more efficiently blow large volumes of smoke up your patient's rear. So our objectives, we're going to talk about the definition, the emergent pre-hospital management, and the disposition of drowning patients. And unfortunately, some things that we will not have time to cover, you see here, and they will be presented by other speakers. So drowning has recently received its very own chain of survival, and as was so eloquently put by Dr. Spillman in another presentation, that that prevention piece should take up 90% of the picture, and only when that fails should we go further down that chain. And I liken it to fire suppression systems and smoke alarms. We will save far more lives from smoke detectors and sprinkler systems than the most high-tech advances in burn surgery and burn therapy. Same in drowning resuscitation. It's prevention, 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 and only unfortunately when that fails do we have to go to that very last link here, which is resuscitation, which is what we are focusing on. So drowning seems simple, right? Somebody goes in the water and dies. Well, before 2002, there were actually 33 different published definitions of drowning, 20 on drowning and 13 on near drowning. And in 2002, at the World Congress on Drowning, we said, we're going to talk about drowning as a process. That process begins when somebody is underwater experiencing respiratory impairment. At some point, that process is going to result in death. At some point before death, severe, moderate, mild, and hopefully no neurologic morbidity. And it's our job as resuscitationists to interrupt that drowning process and prevent its progression towards death. In accordance with the Utstein or Utstein style of reporting, we agreed that we were going to get rid of all of these terms, and we're going to resuscitate and treat all of our drowning patients regardless of the type of water, fresh water, salt water, the same during the initial resuscitation. And I'll talk about some of these other terms in their historical context as we pass through them. So some of the human side of drowning and the idea of morbidity. This is two families that are represented here, both from the Las Vegas area. On the right there is Brianna. Brianna is a medical student right now. Her and her husband bought a house in Las Vegas that had a swimming pool. They recognized the need and the importance for building a fence around it. They saved up money for several months, and her husband even took off work and took his vacation so that he could install the fence that was set to be delivered. 2 weeks before that occurred, their 13-month-old daughter, Claire, got into the backyard pool and died by drowning. She now runs a nonprofit to provide pool fences for low-income families that can't otherwise afford them, and she does media appearances with other families. There with Austin is his mother, Sierra. Austin has a twin sibling, and they were at a backyard pool party when he was 18 months old, and everyone assumed that everyone else was watching them. He was missing for about 45 minutes before they found him on the bottom of the pool. He has severe neurologic morbidity. He's blind, he's deaf, he has a tracheostomy and a PEG tube for feeding, and this is him at about age 9. Unfortunately, just a few months ago, surrounded by his family, on May 31st, then Austin died after struggling with the consequences and the sequelae of a non-fatal drowning. And this is one of the big reasons why the term near drowning is like nails on the chalkboard for me, because there's nothing near about this. This was a non-fatal drowning that many families deal with these consequences for many years through many doctor's visits and the like, and it's emotionally, financially devastating. And so we really need to speak the same language and talk about it as fatal and non-fatal drowning. I know Dr. Behrens is going to cover the physiology of drowning later, but in the context of the resuscitation, I'm going to talk about it briefly. After the initial breath holding and struggle, most people will go unconscious after a short period of time of 30 to 60 seconds. But you can imagine that brain death isn't going to occur for another for about another 10 minutes afterwards. So we have this unconscious period where there is still functioning brain activity. You may still have a heartbeat and other reflexes during that time. So very little water, less than 30 mLs, actually enters into the lungs. And there's a lot of reflexive swallowing. So at autopsy, you may find a liter or more of water in the stomach, but very, very small volumes of water actually in the lungs. And even in dead bodies recovered from water who have died by drowning at autopsy, typically only have 1 to 2 mLs per kg of water within the lungs. We have to get it out of our heads that drowning is a problem of the lungs filling with water. There's actually very little water that enters into the lungs. The studies that were done that said we should treat salt water different from fresh water because there's going to be electrolyte shifts and hemolysis and volume overload were done by Dr. Modell in the 60s and 70s, where he actually took intubated dogs with a breathing tube down the throat, and put up to 44 mLs per kg down their endotracheal tubes. And none of the dogs that received less than 11 mLs per kg had fluid and electrolyte changes. Again, the salt water, fresh water, we're going to treat them all the same, because the big problem of the drowning patient is that they're not getting oxygen to the brain. Drowning is a brain problem and not a lung problem. That small amount of water, even just that 30 to 50 mLs that enters into the lungs, certainly does cause some problems. It can wash away the surfactant, which causes atelectasis or collapse of the alveoli. And our surfactant is this soapy proteinaceous material that mixed with water. You mix soap and water together and shake it up, and what do you get? You get foam, right, which is pulmonary edema, essentially, that comes up and can complicate it. Remember, our alveoli are only one cell layer thick. So as that droplet of water touches that one alveolus, it may cause it to rupture, and you're no longer getting gas exchange. You get hypoxic vasoconstriction of the vasculature going to the lungs, as well as bronchospasm and inflammation of the medium-sized airways, which can make it difficult to affect ventilations in these patients, even if you're doing everything 100% correct. So drowning is a brain problem with some lung complications, but their primary issue is that they are not getting oxygen to the brain. I thought this was poetic, and I'll let you read it. So while much has been debated and discussed about what's a wet drowning, what's a dry drowning, what's a delayed drowning, what's a secondary drowning, at the end of the day, it doesn't matter. Somebody has been deprived of, their brain has been deprived of oxygen. They may as well have been in outer space. And now, as resuscitationists, we must interrupt that drowning process and get oxygen to the brain, because amongst all this crowded discussion and all this crowded lung physiology that people really enjoy debating, they have one problem. They're not getting oxygen to the brain. So if our cause of death or morbidity is anoxic brain injury, what's our treatment? Get oxygen to the brain. There is a wonder drug in the treatment of drowning patients. It is called oxygen. So this is the only graph in the entire presentation, and it's my favorite graph in all of medicine, and I use it for everything. At its most fundamental level, this is a dose-response curve. If we take medication like paracetamol or acetaminophen, a standard dose is 650 milligrams. This says if I take 1 milligram of paracetamol or acetaminophen, I get no response. And then as we come up, I'll gradually get more and more response, and then if I take 1,000,000 milligrams, other than having liver damage, I'm not going to get any more response out of it. But I like to think of every disease process in medicine as a continuum from alive and well to dead. At some point, there is a very rapid progression towards dead. And once you are dead, you can't be any more dead. One of the things that I love about accident and emergency and pre-hospital medicine is that it's not my job to get everyone back to alive and well. Just like you saw in Austin's case, some people never get back to alive and well. It is only my job as the pre-hospital provider to halt the progression towards dead, interrupt their drowning process as quickly as possible and as soon as possible. And if you can get them going back the other way, even just a small amount, then you are doing a phenomenal job. And suffice it to say, if it takes to go from 0 and normal to brain dead in 10 minutes of our drowning patient, if we interrupt their drowning process now, instead of 45, 60, or 90 seconds from now, then they have a better chance at a functional neurologic outcome. This is data from the drowning resuscitation centers in Rio de Janeiro, where they are actually, the fire department is a branch of the military and the lifeguards are a branch of the fire department, and they have physician, nurse, physician, paramedic staffed ambulances and ICU level care at the lifeguard stations. So regardless of the location of the drowning patients, they are often taken to the lifeguard stations where they are attended by a physician. And so they have tremendous experience in dealing with these drowning patients. So of nearly 42,000 rescues during that time frame, the vast majority are treated and released at the scene. But of those that died, how do we predict who needs additional assistance? And I draw your attention here to the center column, which is the percentage of people in each category that died. And rather than fixate on the grades, because Dr. Spillman himself will be discussing this later, if you look at those numbers, 0, 0.5%, 5%, 20%, 45%, 93%, you can imagine that if we put those on a graph, it would look exactly like that first graph that I showed you, that there is a rapid progression towards death. And as we draw our attention here to the grade 4, they have a large amount of foam in their upper airways and they're hypotensive, as defined by not having a radial pulse. Why are they hypotensive? Because they don't have oxygen, right? This isn't a diabetic, hypertensive, renal failure, lung cancer patient that just had a brain transplant on Coumadin, right? This is a very simple, typically otherwise healthy person who has been starved of oxygen and needs oxygen. And the way I look at this is your natural progression of your drowning patient. If you give them oxygen, they get better and they get a blood pressure back. If you don't, then they stop breathing. When they stop breathing, then they go into cardiopulmonary arrest. So this, to me, looks like the natural progression of your drowning patient, or the natural history of your drowning patient. This is Maya Gabeira. Maya is a professional big wave surfer out of Brazil. She was just dropped off by her partner Carlos on the jet ski, and as she's dropping in on this 20-meter wave, she wipes out, which we'll see again in slow-mo. So Olympic quality athlete, professional big wave surfer, they drop in and they do this all the time. They practice these rescues and these pickups. She is wearing a life jacket, and while this is certainly a big wipeout, one thing that complicated this is as she fell, she broke her ankle. She actually shattered her distal fibula as she hit the water. So here we see her struggling. Carlos comes around to pick her up. He's actually going to hit her in the chest with the sled, which is what they normally do. Every other time they perform this rescue, she would grab on right there. He realizes something's wrong, but another wave is coming, so he has to get out of the impact zone. She's held down for about another 30 seconds before he can come back around, realizes something is wrong and reaches down to pick her up, but she's unable to grab, but she holds on to the tow rope. Right? He can't go any faster because she's going to fall off. He can't go any slower because the wave comes, and now she is unconscious, unresponsive right here. She has respiratory impairment as a result of submersion or immersion in the water. She is drowning. So Carlos comes back around to pick her up. He's saying that we are in waist deep water, but we're getting hit by 5 meters of white water, and he continues to get her up onto the shore. So in the subsequent interview, when he pulls Maya up onto the beach, he starts doing chest compression only CPR, said that he's took a class and that you no longer have to do mouth to mouth as part of CPR anymore. So that's actually Carlos straddling over Maya right there, and the person at her head is Nuno Oliveira. Nuno is a Portuguese lifeguard who was just hired on by Red Bull as an extra. So we're going to shift away from Maya for a moment and take this to be another hypothetical patient, and we'll come back to Maya's course and outcome momentarily. But transitioning to a hypothetical patient, you've just pulled your patient from the ocean. Their airway is open, but they have a lot of foam. They're breathing very fast and very shallow. They're starting to get tired. Their heart rate is rapid. Their blood pressure is getting weak. So what is our critical action, right? We already talked about why is their blood pressure getting low? Because they don't have oxygen. We need to focus on the airway with ventilation and oxygenation. And it can't be overstated enough how important it is to start basic. Start with the basics. If all you have is mouth to mouth, start with mouth to mouth. If all you have is a bag valve mask, then start with that. For those of you in developed systems, going straight to endotracheal intubation or rapid sequence induction can be a fatal maneuver for the patient. A lot of these, particularly those of you in urban EMS systems, this may be the only time that you resuscitate a 3-year-old from a full arrest that looks exactly like your 4-year-old that was just pulled from a swimming pool without a fence, just like the one that's at your house right now. So these can be very emotionally difficult. A lot of these patients have airway obstruction from foam, sand, mud, McDonald's. Did a similar presentation for an EMS system at a large urban center, and they shared a story of a 4-year-old backyard pool party that was pulled out from drowning, was pulseless and apneic, and they had a lot of difficulty clearing the airway because he had eaten so many hot dogs and cake that as this was coming back up, it was too thick for the suction, but too mushy for the forceps to try and maneuver. So the airway can be very difficult to manage from that standpoint. Even if you're doing everything 100% correct, it can be difficult to overcome the decreased compliance of the lungs. A large percentage of these patients will vomit. From an Australian study, it's nearly 90%, which can really make the management difficult. If there's anything that you guys take from this presentation, I want it to be a fundamental understanding of this. The American Heart Association, ILCOR, Australian Resuscitation Council, European Resuscitation Council, CPR guidelines that we all look to as gospel and know and love are written by cardiologists to save out-of-hospital witnessed VFib, VTAC arrest patients. Everything else is a special case. So take, for example, me. I'm 65 years old. I smoke 2 packs a day. I have my yolk-only omelet with my pound of bacon in the morning before going to Walmart. And as I arrive at Walmart, I suddenly collapse. Why? Because I've gone into ventricular fibrillation or ventricular tachycardia as a result of having poor heart health. For those of you that are UFC or Brazilian Jiu-Jitsu fans, if you take a world-class athlete like a Brazilian Jiu-Jitsu fighter and you put them in a choke that occludes both carotid arteries, they go unconscious after about 5 seconds. So a world-class athlete with no blood flow to the brain is unconscious in about 5 seconds. Now go back to our 65-year-old with a poor heart at Walmart. Just a few seconds of not getting blood flow to the brain from VFib or VTAC, and they are going to go unconscious. They will still have several minutes, 4 to 6 minutes of oxygen still within the blood and within the physiological dead space within the lungs. So the focus should be on compressions, compressions, compressions. Circulate the blood that's already there. But even the best chest compression is only going to give them about 25% of their cardiac output. So we need to get a defibrillator on them and shock them so that we can get them back into a perfusing rhythm so they can pump their own blood to the brain. Then they're going to go to the hospital, potentially therapeutic hypothermia, cath lab, long-term lifestyle modifications, and the entire downstream effects from there. The focus should be on getting a defibrillator on them and doing chest compressions. Now I'm me, otherwise healthy, 34-year-old guy. I'm out surfing and I get trapped underwater. My oxygen saturation starts to drop, 90, 60, 40, 20, 0. At some point, my heart runs out of enough oxygen and circulating epinephrine, adrenaline, to keep beating. But I still have enough circulating oxygen and adrenaline that the cells of the heart are firing off electrical signals that can be picked up on a monitor. This is pulseless electrical activity. And then at some point, I run out of enough oxygen substrate for even that, and then I have the proverbial flatline, asystole. So you pull me out of the water, and what's the first thing that you want to do? Right? Not chest compressions, as many of you would answer and have been taught. Your chest compressions are only going to circulate 25% of the 0 that I was circulating just fine before you arrived. The focus must be on the airway. If you start chest compressions without first giving oxygen, then you are trying to start a car with an empty tank. You have to refill the tank first. So the European Resuscitation Council guidelines are currently for giving 5 immediate rescue breaths. Every other council worldwide advocates for 2, I believe as a matter of simplicity, so as not to make the guidelines any different. But you must reverse the hypoxia. You must interrupt their drowning process by providing oxygen to the brain as soon as you encounter your drowning patient. It becomes a matter of academic discussion of, do I do my chest compressions first and then my ventilations, or my ventilations and my chest compressions? And at the end of the day, it doesn't matter. Because if you start with chest compressions and that delays giving the breath an additional 15 seconds, we don't know that that's necessarily going to make a difference in the outcome. But where it matters is if you're doing compression-only CPR. Compression-only CPR is absolutely incorrect. So in cardiac causes of basic and advanced life support, the heart stops. You need to circulate the oxygen that's already there as a temporizing measure till defibrillation. CAB, or continuous chest compressions. Drowning, kids, trauma, everything except witnessed VFib, VTAC out of hospital arrests. The heart stops because there's no oxygen in the blood, and we need to continue with our ABC paradigm. At least at the American Heart Association, this is a little frustrating because here it is in black and white. Unfortunately, this text does not appear in the instructor or the student manuals for when these courses are taught. So this nuance is lost on many. So as soon as Nuno started doing mouth-to-mouth, there was a discussion back and forth in the heat of the moment, and certainly not to discredit either of the rescuers, as to whether or not mouth-to-mouth was needed, because the discussion was we need to just do chest compressions, just do chest compressions. But as soon as Nuno gave Maya a few breaths, then she started breathing a little on her own, and she actually tweeted this picture just 4 hours after arriving at the hospital. And we would expect that just based on the short amount of time that she was unconscious, that she still had circulating oxygen and that she still had a strong blood pressure, and so she would have been in the drowning grade that only carried a 5% mortality. And here she was just before hospital discharge, 6 hours later. She tweeted this picture of her ankle fracture approximately 1 month later at follow-up. And to tell you how absolutely insane some of these pro big wave surfers are, Carlos actually went back out surfing after she left the hospital and caught what was arguably considered to be the largest wave ever surfed at 33 meters. So in-water resuscitation, for those of you that are aquatic rescue professionals and proficient and trained in this, then they have a higher chance of survival. For those of you that are not, this is a technically difficult task. It only benefits the patient that is apneic but still has a pulse. If they don't have a pulse, they need to be removed from the water immediately because you can't perform chest compressions in the water. If they're over 55 and they've had a primary cardiac arrest while in the water, and that's the reason that you're having to rescue them, in-water resuscitation is not for them. They need to be removed immediately from the water so that you can do your circulation and get your defibrillator on them. For the rest of the world, this is the best evidence that we have that shows the sooner we interrupt their drowning process, the better chance they have at a neurologically intact survival. And while there's a lot of discussion amongst agencies who use and don't use in-water resuscitation, it is the best evidence that we have that says the sooner we interrupt their drowning process, the better chance they have at a neurologically intact survival. And they actually make specific devices. I don't have any commercial interest in any of them, but for those agencies that do use in-water resuscitation, don't use the masks with a paper filter. They make ones with a mechanical filter. It seems silly, but many of the agencies that I work with and that I speak to have never considered that before. So if you are going to incorporate in-water resuscitation, then you need to plan and train appropriately for it. These special considerations will be covered by other speakers later today, so I won't discuss them now. 5 minutes. Thanks. So we're briefly going to watch a couple of videos. I don't know the context of this video. It was found online as is, but it demonstrates a couple of points. One is the Heimlich maneuver. This is something that Dr. Heimlich really advocated for, his maneuver as a cure for asthma, cystic fibrosis, drowning, as well as foreign body airway obstructions. And it is something that has persisted, and it makes sense. If you think that drowning is because somebody is full of water and you squeeze them and water shoots out, it makes you feel as though you're doing some good. It is not. You see here she has foam coming from the airway, and he's actually pouring water to try and clear the foam from her upper airways. So the idea of the foam in these drowning patients, again, we just have this small volume of water that is coming up and is going to continue coming up. And you take a small volume of water, mix it with soap and shake it up, and it's going to produce large volumes of foam. If you spend time aggressively suctioning in the pre-hospital setting this foam, you can spend the rest of their life suctioning them, and it's going to keep on coming. So in our patients that have foam, it goes against everything you've ever learned as a pre-hospital provider that you need to clear the airway. If it's frank water or vomit that comes up, of course, suction it and clear the airway. But if it's just this foam that's coming up, you can just bag it back down. It's just pulmonary edema. We will deal with it when they get to the hospital because right now they are acutely dying of a lack of oxygen to the brain. So I need you to resuscitate their brain because if you bring them to the emergency department with dry lungs and a dead brain, that's not a salvageable patient. But if you bring them to the emergency department with an intact brain and wet lungs, we can work around that. In some centers, we can bypass the lungs completely and put them on devices. Once we get definitive airway control, we can do deeper and other types of suctioning. This is the last video that we'll show. And it, again, is an unsuccessful resuscitation in the initial phases, but you see this copious amount of foam that's coming up, and these well-intentioned bystanders just want to do something. And so they're pumping her stomach to try and get this out. So what I advocate for a drowning treatment algorithm is, as soon as you encounter your drowning patient, if you have a bag valve mask or a bag valve resuscitator, then immediately just start providing bag mask ventilations to your patient. Even if you're not hooked up to oxygen yet, that's okay. The oxygen concentration in room air now is better than 100% oxygen provided 2, 3, or 5 minutes from now. If you don't have equipment, then you're going to immediately start with mouth-to-mouth resuscitation. If your patient reaches up and grabs your hand while you're trying to use the bag mask resuscitator, then you can de-escalate, use a non-rebreather, use a simple face mask, or whatever other equipment is available. We all agree that this patient needs advanced airway intervention. We all agree that she is in very bad shape. However, if you try and start with the advanced maneuvers, then that is not the best chance for survival. You need to start with the basic maneuvers. This is one algorithm that was proposed by Dr. Peter Antevi, who is a pediatric emergency medicine medical director out of South Florida. Again, as soon as you arrive on scene, start your bag mask ventilations, then check for a pulse and determine if you need to compress. Drill is for using an intraosseous device for his specific system, and then consider your epinephrine or your pediatric or adult advanced life support measures. Again, this is not appropriate for everyone, but this is one such system that is used to address the acute phase. 2 minutes. Thanks. So I love collecting old CPR and training manuals, and this one actually came from the Canadian Red Cross in 1962, and which predates what we consider to be modern CPR, and it's train every member of your family in mouth-to-mouth. No need for delay. Start rescue breathing as soon as you reach the victim. Interrupt that drowning process as quickly as possible. You can do it in bed, on the floor, on the street, in a car, in a boat, in the water. Saving time will save more lives. Interrupt their drowning process as quickly as possible. So in closing, really appreciate drowning as a process and not as an outcome. Drowning is a brain problem, not a lung problem. Resuscitate the brain. Interrupt their drowning process. Oxygen, oxygen, oxygen. Don't forget to warm them up. Anticipate that they're going to vomit, but ignore the foam. Don't spend your time suctioning or trying to clear the foam. Really appreciate the hypoxic versus cardiac causes of arrest. The guidelines for the continuous and chest compression only are written for witnessed VFib, VTAC, out-of-hospital cardiac arrest. Drowning is a special case. And all of your symptomatic patients should be taken to advanced care. And with that, I'll be happy to take any questions. Thank you.
Through one of the evals, you guys had brought up the fact that some of the EMTs wanted to go over this, determination of death. Is this an EMT skill? Okay, so right off the bat, there might be some things that you see when you walk in the door. However, all these patients need a thorough medical evaluation. And if they meet these first 3 criteria, then your job's pretty much done. So these are the heavy hitters, the decapitation, so missing a head, their body is already starting to decompose, and then they're just completely charred, incinerated. I did have a call though that the person was alive, but man, I thought they were close to number 2. I went to this moto home park on South Salinas where this guy had been doing whippets for, it seemed like months. So just, inhaling the nitrous through those cartridges, and he was laying face down on his motorhome linoleum. And he had so many of those metal cylinders, as you can imagine, they're not easily stacked on top of each other, but he had just been tossing them to the side to where the sides of the motorhome, they had gained in altitude. Those metal cylinders were stacking on top of each other. And his torso had solidified to the linoleum. And he didn't want to go. He just wanted to continue. I was just like so flabbergasted at one, how he got there are boxes, big old boxes filled with little boxes full of all those things, and they just kept coming and just kept going strong.
Didn't die happy, at least.
He was excited to do that. And the person that called was his ex-wife, so I know there's some weird things going on. Anyways, he was very close to decomposition.
Did we, or did the county ever have hemicorporectomy? That's the fourth one? Or is that not been accounting?
Maybe I've heard it before because maybe I saw that because I started in Ventura, but I know that is.
That's the Ventura one.
What was that?
Cut in half? Oh.
Yeah, so there's been issues. I know Bobby had one where it was a train versus a head. They didn't meet any of those, but the guy's heart was like in another place. So it doesn't.
That meets evisceration, right? 3A here. We'll talk about it. All right, so this is the lividity. This is just a case, but basically as you pass, now all these fluids are subject to gravity, and so a lot of the stuff will settle down at the bottom part, and most of the time you can use that as a trigger to kind of go down this route. What's rigor mortis?
Stiff.
When does that set in? You guys know?
There she is.
4 to 6 hours. What is it? What causes it? Not that you need to know, but just so you guys have an understanding. That was 4 to 6 hours. We no longer produce ATP, which is like every cell uses as an energy source. And out of those myelin fibers, we no longer can move them. They just like lock together. If you can imagine them as like little serrated edges, they just get caught. And they can't move without ATP until about, I think it's 24 to 48 hours where those myelin fibers actually start to decompose. So when you go on a call where a person's, a welfare check, and they might have been dead for a long time, like 3 days, and they're moving, it's because of that. It's because we're actually starting to decompose those fibers. We're past like the rigor stage. So just so you guys know, so yeah, 4 to 6 hours is when it usually sets in, and it'll last up to that 24 to 48 hour mark, and then it'll start to break down and you actually be able to move them. So don't be weirded out if those body parts are moving, because we're past that stage. And then evisceration of heart or brain. So what is that? What do you guys think that means? Just because we need to define all this stuff, because you guys are going to be writing about it, right?
It's outside of the body.
Okay. I think it was near guys' neighborhood. I ran a call in Eucalyptus Hill. These two people had been up all night smoking crack, and then she convinced him it was a good idea for him to get on the car and for her to surf on the hood down the hill. Was it East Valley? It wasn't that one where like there's multiple kids. This is a different case.
I think it was also when he saw the car, she was surfing, car surfing.
Yeah. It was like, well, I don't know, I was on ambulance a long time ago. Yeah, okay. Yeah, that might be the right window. So I went up to her and I just had like brain matter in my hands, right? So then what's my job? What do I got to do? We got to do B through E. Yeah, so we're leading into what all the other things that we need to do, which you got it right. So we got to open the airway and check for respiration for 1 minute. You can either palpate for a carotid, or the easiest thing, and you guys is about like creating data, right? So just the CYA is to put them on a monitor and record it, so you have it always there. Check pupils, and then check pain response. I had a guy once, and I'm sure you guys have all kinds of stories too, and feel free to share. But at Pershing Park, he had been cross-legged, a homeless gentleman, and he had kind of like fallen asleep like over his cross leg. So imagine him sitting in Indian style, and then he kind of folded himself over. And a friend of his said that they'd been drinking like through the night, but he had been in this position for like several hours. And so he had, I don't remember exactly, but I remember we pull him up and his legs came with him, you know, so it was this rigor. But at the same time, I was questioning myself because probably through some type of gas exchange and or like an occluded airway, all of a sudden there was a like a sound like, oh my gosh, like what do we do now, you know? So we just did the B through E just to kind of document all that stuff.
You know, it's funny that you have to go through that if somebody, you know, if their heart is 10 feet away from their body, you know, then you did like, you almost look like you don't know what you're doing if you're shining a light in their eyes.
Right. People are like,
no, check people are responding.
Yeah.
Dude, his heart's over here.
Yeah. No, I can imagine that's a difficult thing to do, especially if there's family members there. Like, why are you messing with this guy? You've already called him dead. Difficult situation. Any questions about this portion? There's still a little bit more. But the main thing is just if you say that they have any parts in A, you have to do B through E. That should be documented in your narrative or someplace. All right, so if all that applies, then you no longer need to do any medical care. Patients to be determined dead and anybody else that's on their way can be canceled. The EMT who responds after the patient is determined dead does not need to reevaluate. Base hospital contact is not required unless, man, there's just some oddity. And again, this is a great place for you guys to record some information just for your benefit. Coroner's office and law enforcement agency must be notified. If the death appears to be from other than natural causes, just be aware of evidence and don't disturb it. And then law enforcement personnel have the authority to determine death. If this has occurred, the EMT does not need to reevaluate. This is all just right off of your guys' policies. So any questions about any of this stuff? A couple of people have asked me if airway is the key. Do we want to hyperventilate, or like what do we want to do? And I thought that was a great question. The answer is we're just going to use our rescue vest like we do normally. Well, why is the BVM important in this foam that he was talking about?
Able to push through that layer of, you know, water into the interstitial space to get that oxygenation going.
Yeah, so I mean, it works the way CPAP, and it also works the way nitroglycerin works. So we're basically dealing with pressure differential. So nitroglycerin, if we enlarge the vessels, we reduce the pressure, and so we'll help push that pedal edema out. We put CPAP on, we increase the pressure in the lungs, which is higher than the vascular. We're going to push that fluid out into the vascular system by having the BVM. He obviously, he said, like frank water or vomit, we're going to want to suction that out. But if it's just the foam, that pressure of that BVM and or the mouth-to-mouth that he advocates is enough to oxygenate that patient. Which all this was very new to me because I'm coming here fresh off of what I just taught. It's hundreds of people CAM, new updates, here we are, like airways going down, 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 down. But when he defines it as cardiologists are writing this for just those two special cases, a lot of this makes sense. I'm not here to say that we're changing policy, but this is up for discussion. These are, you know, this is why policies change all the time, is because we think about new things. So all that seems pretty reasonable. Anybody else have anything different? I'll tell you what, if I was responding on a drowning now with this knowledge, I think I'd be like a step ahead as like how important things are at a crucial time. So I was pretty stoked to find that. And man, I mean, you guys know this just as well as me, but I think I remember every single drowning call that I've ever been on, and they are not fun. A lot of hysteria, a lot of people involved. I think this is getting into our last little area here. Poisoning and overdose. Narcan was the big thing this year, and unfortunately under this policy, an EMT can only deliver this Narcan, which has been very successful, by the way. I think in the past 3 months, I was looking at data where we have 13 saves in 3 months from Narcan administration in the county. So that whole program has been very successful. Last week, I had to chase down a family member who was very accepting, but the patient wasn't. After being waken up in the ER, he ran out. And, you know, I'm not going to run after people, but I knew that the family member was bummed that he was leaving. And so I caught up to her and was able to have like 5 minutes of Narcan training because she was super into it and obviously frustrated at their loved one's actions. But that's not the come to Jesus moment. But in the process of the disease, hopefully she can be there if this ever happens again. But since Narcan is the only thing you guys, or that EMTs can do under this policy, and I'm a fan of, you know what you need to know and then know the next step. What is the medicine that you see most often given by medics in a poisoning or overdose case besides this Narcan?
Besides Narcan?
Yeah. I mean, I'm not talking about an opiate overdose per se. I'm talking about. Yeah, great. So we're going to discuss a little bit about this. What is it, and why does it work, and that sort of thing. So why does it have this activated? Well, the difference between that and regular charcoal is that they've heated it up to a tremendous amount of heat, or put alkalis or acids to create more surface area. So the reason this stuff works well is because it just has a tremendous amount of area to absorb whatever they had ingested. Activated charcoal is not an antidote, but through absorption, we're basically binding that substance to prevent the body from leaching it into our system. That's what it looks like. Electron microscope. He'll talk about in a minute that 5 grams has a surface area between 500 and 1,500 square meters. And we're giving, I think, 50 grams? So a tremendous amount of surface area.
From the way it's marketed, you'd think activated charcoal was some kind of miracle powder. It's best known as a treatment for poisoning, like if a kid accidentally swallowed some cleaning supplies or for filtering water. But activated charcoal has made its way into all kinds of stuff, like teeth whitening products, cosmetics, and that black ice cream from your Instagram feed last summer. Now, I hate to break it to you, but it's probably not the magical health supplement that some people claim it is. Charcoal is a black residue that forms after you burn something with lots of carbon in it, like coal or coconut shells. To make activated charcoal, also known as activated carbon, you treat charcoal with heat and oxygen or with certain acids and bases. These chemical reactions can rearrange the carbon atoms to form lots of tiny pores, so activated charcoal has a huge surface area. In fact, just 1 gram of it can have from 500 to 1,500 square meters of surface area. That's as much as a globe more than 4 stories tall. And that lets it trap certain molecules really well through a process called adsorption. Now, I'm not talking about absorption, where chemicals get trapped inside something, like water soaking into a rag. Adsorption means molecules bind to the surface of another compound, like the carbon-lined pores in activated charcoal. The molecules bind because of van der Waals forces, the weak attractive force between uncharged molecules. Basically, depending on where the electrons are, one side of a molecule might be more electrically charged than the other, even if a molecule doesn't have an overall charge. So when a molecule passes through the tiny pores in the activated charcoal, those very weak charges make it cling to the carbon thanks to van der Waals forces. Activated charcoal is good at collecting molecules that contain carbon, like most poisons, because they're usually large enough and have enough electrons to have stronger van der Waals interactions. But it can absorb other molecules too, like iodine. And because activated charcoal has such a large surface area, there are plenty of places for poison molecules to bond. Then the charcoal passes harmlessly through your digestive tract instead of getting sucked into your body, so the poison can't spread and mess things up, which is always a plus. Plenty of studies have been done about it binding poisons in humans or toxins in a water treatment plant, so there's no doubt that it works for those things. But people have also claimed it can help with hangovers, whiten your teeth, reduce gas in your intestines, and purify mysterious toxins that supposedly build up in your body during normal life. And the evidence there is less clear. Some people claim to get whiter teeth from activated charcoal toothpaste, but no one's done research on it yet. There's also contradictory results about whether it can help with gas by binding to molecules that contain sulfur, and there's no evidence that it'll absorb alcohol or help with hangovers. So activated charcoal is definitely safe to eat, and might be great for some things, but any miraculous health benefits from eating a black burger bun are probably too good to be true.
So it works with a tremendous amount of chemicals. Basically, and those things we're constantly adding chemicals to a list that activated charcoal would work for. But it's so much easier in your policies to just talk about areas where it won't work, and which is how it's written. But before we get into that, you guys can call Poison Control Hotline, which is this number here, and basically start not only the treatment, but start a call that will inadvertently happen when they get there. But it'll, here's what you gotta have. You gotta have a couple things. Hopefully you have a substance, and you can have a name and maybe the amount of it. And then you also need a time, so kind of like a stroke. You need to figure out, hopefully, ingestion, when did that started. But you can call this number and they'll basically talk about the treatment, yes or no on charcoal, or maybe do this other thing, and then you can pass that information on when you bring that patient to the hospital. Here's when we don't use it. No, we're altered enough to where we don't think that they can safely ingest 50 grams of black lipstick that we might choke or aspirate. People that have taken anything like these oven cleaners, drain cleaners, toilet bowl cleaners, bleach, that sort of thing. And this young man who has maybe gas prices are too high, and so he's siphoning some gasoline for his rig. But just the vapor is enough we're talking about like occluding that area just because of some substance, but just the vapors of gasoline is enough to occlude that, where you get this really long, like coughing attack, like minutes long. It's very irritating, let alone getting gas in your lungs. But if you do have gasoline, you're not going to give activated charcoal. Any questions about activated charcoal? Again, it was a very small list of when not to give it. Most of the time, it's given within an hour of ingestion to thousands and thousands of chemicals, which we'll kind of get into next. A little segue. What substance do you think causes the most common hospitalization of overdose patients?
Aspirin.
I didn't hear the first one. Opioid. Acetaminophen. Most common cause of hospitalization of overdose patients. That seems kind of weird, but we'll get into why that's the case. Problem is that it's in a ton and ton of products. And so you're sick, you've got this flu that we talked about earlier, so you've got this temperature, your whole body aches. And so you grab some like Tylenol for your body aches, and you grab say NyQuil because you need to go to sleep, and the list goes on and on and on of things that you're trying to do to make yourself comfortable, right? Because it's a crappy situation. So the maximum adult dose is 4,000 milligrams a day, but I'm here to tell you too that if you do that over day, you're also going to have acetaminophen toxicity and poisoning, and you could you could get in a lot of hurt. So I'm not sure if all you guys can see this, but I'll just kind of list the heavy hitters or ones that you've heard of that have it. So Vicodin, Vicks, obviously all the Tylenol, Theraflu, Sudafed, Sinutab, Percocet, Lortab, Robitussin, NyQuil, Midol, Excedrin, any of the hydrocodones, Dayquil, Benadryl, Alka-Seltzer. You can see how these people can get in it bind. Other people that risk are people that are hard on the liver, people that have one of the hepatitis where that thing's already irritated. We're talking about a filtration system that all of a sudden gets bombarded by acetaminophen, and it's very toxic to the liver. Well, another issue is that we have parents that are like, well, the label says this much will work for my child, but a little bit more of the good stuff will probably make my child feel even better. So it's a very common thing, and parents aren't trying to overdose their child. They think this stuff is relatively safe. They purchase it over the counter, so they give a little more thinking that's going to help their child out. Very common. And we're talking the single overdose can have acute liver failure, but we just talked also that several days of taking too much of something will cause, or of taking acetaminophen can cause similar issues. Some common symptoms: abdominal pain, loss of appetite, nausea, vomiting, fatigue. Those are super vague. And then at the very bottom, we get into stuff that's like, they're, way down the road, where we have unusual bleeding, some jaundice type findings, and flu-like symptoms. So what's our treatment? First, you guys are going to give some activated charcoal in the field. 1 gram per kilogram, or to a max of 50. But you're absolutely right. So this is acetylcysteine, and basically the way that this works is, as the acetaminophen is broken down, there's a mediary product that is toxic to the liver. And so this helps prevent a certain aspect in the chain of breaking it down to prevent damage to the liver. So without getting into the nuts and bolts of it, as it gets through the broken down process, we basically stop it at a certain point before it gets toxic to the liver.
Time sensitive then?
Well, yeah, the longer, or I should say the shorter that we can administer that, the better, yes. Yeah. Any questions about any of that? Just be aware, guys, that, I mean, that product is in hundreds and hundreds of over-the-counter stuff. And for you guys, it would just be a good chance to just update patients on, hey, do you realize this and this? You guys know a lot about this, but what's the most common inhaled poison?
Carbon monoxide.
What's this saying on the right-hand side? Basically, you might be in that area and not even know it, right? Because we can't see it, can't smell it, doesn't make a sound. This is an issue, obviously, a lot in colder climates, where people have more carbon monoxide poisonings. But we can run into it here, either through industrial accidents or attempted suicides. It is implicated in more deaths than any other toxin except alcohol. Exerts this toxic effect by binding the circulating hemoglobin, thereby reducing the oxygen carrying capacity. And as you guys all know, that it has 200 times more affinity, or more readily absorbed than oxygen to our hemoglobin. Some of the findings, it's mild is the headache, nausea, and vomiting, but then we get into confusion, drowsiness, tachycardia, those kind of symptoms, and it has this CNS issue where the person just may appear intoxicated. They have all the symptoms. We talked about some of these: muscular weakness, palpitations, dizziness, and confusion, which could lead to death. And the skin color that they always talk about is kind of a late finding, and I've personally never seen it, but it's talked about in books about you can have this cherry red appearance. And what's the issue with this pulse ox?
False reading. False reading is the finding of the hemoglobin.
So, yes. So, tell me the physiology of the pulse oximeter. Like, what is it doing?
Measures the open sites.
Sending light onto your blood.
Yeah, and he's got it right. Like, it measures the saturation of your hemoglobin, right? That's its job. And so you're getting 100% on a CO2 or carbon monoxide overdose. Why is that? It's because the hemoglobin is completely saturated. It's doing its job. It's telling you the right number. Unfortunately for us, it's not carrying the oxygen that we need to. It's carrying the carbon monoxide. What's our treatment for this type of patient? Yeah, exactly right. I'm sorry?
Fresh air.
One of these guys? Is that what you guys are talking about? We don't really have one of these around. I mean, we do have oxygen hyperbaric treatment out in Goleta, but it's not used on an emergent basis for carbon monoxide poisoning. Every time talk about this, people mention like Catalina, of course, there's a dive center out there. But I wanted to say for a while that Camarillo had something like this. I don't know if it was because of the base that's there, and I don't even know if that's still there. But in terms of how it's going to help us, it's basically a matter of half-life. So without any type of oxygen, we're going 250 to 320 minutes of completely saturated hemoglobin with carbon monoxide, which is not good for the brain, right? High flow O2, or break that all the way down to 90 minutes. And with a hyperbaric chamber, our half-life of carbon monoxide, we can get it all the way down to 30 minutes. And I don't have to talk about the pertinence to you guys in your line of work. Your monitors now, does this life pack, you can detect that. Okay, that's great. We can go over this test real quick, since I think most of it has been answered. Some of it is a little bit tricky question, but number one, the decision of when to use activated charcoal is best made. C, with medical direction or consultation with the Poison Control Center. Number two, you have a standing order to give activated charcoal if the patient meets criteria. Activated charcoal is used to reduce the amount of poison absorbed by the body. Perfect. Number three, you're treating a 28-year-old male who accidentally ingested poison. Activated charcoal is not routinely used with the ingestion of D, all the above. Number four, your patient is a 32-year-old male who has signs and symptoms of poison inhalation. The most common inhaled poison is A, carbon monoxide. Number five, your patient is one of the 5 members of the family who may have been exposed to a leaking heating system and or carbon monoxide, like we just talked about. How does carbon monoxide affect the body? B, it prevents the normal carrying of oxygen by the red blood cells. And last but not least, number 6, during a drowning submersion incident, water flowing past the epiglottis causes. See, we didn't talk about this, but I figured that you guys could have even got it by just a process of elimination. It definitely doesn't cause the mouth to close by reflex. The patient does not gasp for more air when they're drowning, and the patient does not begin to hyperventilate. So the answer is C, a reflex spasm of the larynx. Every once in a while I'll try to do this for you guys, just kind of give you up to speed as far as medical journals go, and these are all just talking points. So I got 3 of them today. This is basically talking about out of 100 people that were discharged using Google Translate with a Chinese instruction and then reinterpreted by a professional interpreter, 8% of these showed potential for significant harm. And these are very detailed hospital discharges. That being said, the amount of detail that you'll need in doing an assessment and or a few basic instructions when you guys are out on the field, I imagine that the chances of you guys causing harm would be much lower. Case in point, a couple of weeks ago, I had a German family, there's 3 of them. The dad, or I think it was like the grandfather, he had cut a digit off with a circular saw. And I was in triage, and I think the triage note from our greeter said something about German only. So as they were walking in, I pulled up Google Translate, and as soon as they came in, the patient sat down, and to the other 2, I just wrote in, "I got this, go get the finger." And like immediately they knew what was up, and boom, they're out the door. So it's like, you can do this by voice command too. There's apps that work really well that you can just like, hey, like, when did this start? And it'll audibly speak, and then they can speak back into it, and you'll get data. So this stuff works well, and there's data to back you. 2 of 3. This is a test or a trial. I was thinking about it as we were going to the stroke. So these guys tried pre-hospital nitroglycerin, and this is a blood pressure control. So as our brain realizes that there's an occlusion, it raises that blood pressure to try to basically push around it. Well, the problem is the pressure gets so high that we actually start the infarction process quicker. And so this test was like, hey, why don't we try some pre-hospital nitroglycerin to see if this would help out. And it had no change in neurological outcome. So these are all just talking points. And last but not least, this stuff just seems like it'll never die. Pre-hospital advanced airway management for adults with out-of-hospital cardiac arrest. So this is February of 2019. Where is the, I thought so 16,000 patients involved in the study. Slightly better survival rate, but no change in their neurological outcome to their, back to where they were. So the stuff is constantly being hammered. There will always be epinephrine and advanced airway management studies, and your policy is written by data. So just stuff to talk about.
So that's saying that more people survive, but nobody's walking out of the hospital at a higher rate if they're intubated.